Hello, I'm Adrienne Hushke, and in this module, we'll be doing RITS training. So from this module, I hope to discuss the RITS rating descriptors more in depth, discuss various resources for scoring assistance, discuss and practice scoring methods using case studies. I will be also adding in, or there are 3 additional case studies in this presentation. I will not personally be going over them, but you guys can pause the video and practice them in your groups. I will be giving an overview of functional use examples of the RITS ratings using some of the case studies we go over. And then finally, I'll just briefly introduce using RITS scores during rounds. So first of all, you all should have a packet of most of these worksheets and information in front of you. And if not, I know Lindsay Marth has access to all of these. So you can ask her. This first worksheet just breaks up the 7 main categories within the rating descriptors into a more visually organized way of viewing the scores. So 4, as I said, is the green box down here, and that's the average engagement. And that's what they found, the normal distribution found as the most common score in an inpatient session. The main differences here, I'm not going to read all the details of each of these boxes. You can definitely do that on your own. But the main differences I want to point out is what will get a patient to go above an average engagement is that they will sustain full attention and goal-directed activity, meaning this is a patient you don't have to remind to stay on task and to attend to their activity. Also, they will adjust their activity based on the feedback that you give them. 4, they're generally attentive and they'll follow instructions. They don't seek feedback, and they'll only occasionally adjust activities or adjust activities to a certain extent based on your feedback, but not fully. If we look at the engagement scores of a 2 and a 3, which are below average and minimal engagement, where you'll see this score come into play is those who are inconsistently attentive. So those that are requiring pretty frequent verbal cues to maintain focus on the task that you have in front of them. And these, they kind of decrease in their responsiveness to feedback. You see these people either not attempting therapy tasks or giving up easily. And these are the ones that usually require repetition of instructions. And then you have the 1, which is absence of effort. This is usually, not usually, but whether it's cognitive, physical, psychological, fatigue-wise, any of those reasons why a patient may not be able to engage or attempt an activity, whatever the reason may be, these are patients, a score of 1 are patients that they just really cannot attend to anything you are telling them. Whether they refuse or they outright refuse, or just, like I said, cognitively, psychologically, physically, fatigue-wise, unable to comply with what you tell them to. A lot of times this leads to early termination of sessions. And less so on their part of asking to be completed, but more due to the part where they just cannot maintain attention for a session to be useful. So there are various scoring tools available, you'll see in that packet, and it's totally up to you what you find most beneficial. You can use any, all of them, none of them. This worksheet is one that I created, and this is, I would say, it's a higher burden as far as it takes a lot more time and energy, and it's a lot more detail oriented. So this is not something that you're going to want to be filling out every day after every session. So this is more intended to use as you're learning how to utilize and score the scale, because it breaks up and details all the 7 categories that the scale looks at. And then it defines each score level. So how this worksheet works is you go through after every session and say, okay, initiating activities. Which of these best describes my patient? Then you would put a check mark. At the end, you add up all your scores. And for the lines that have multiple scores, like the 4, 3, 2, and 1, you would only add the 4, so the first number you see in the line. Once you get a total score, you're going to divide that by 7. Oftentimes, you're going to get a decimal. Don't initially round up or down, because that score, let's say you get a 3.8. That means that that person very solidly scores a 3, level 3. However, utilizing your clinical judgment, maybe it's like, well, actually, I think they seem like they would be more of a 4 or more of a 2. So the fine rounding is less of a mathematical rounding and more of a clinical judgment rounding up or down of an engagement score. This decision tree, which actually I did make one edit to this, so the one in your packet is the up-to-date and the rest of the slides are going to be up-to-date. I had to add one extra box in here. So this tool is definitely low burden, very good for in-clinic use. It's very easy to follow. It does not take a lot of time to follow. However, I will say the one thing about this to be careful with, if you are unaware of some of the differences between 2 levels, you may tend to get a generalized score that will either over or underscore your veteran if you aren't careful. So now we're going to look over a few case studies and practice scoring them. Let me grab out a highlighter. Okay. So in this first case study, we have Miss Jolene. She's a 45-year-old active duty Army engineer, currently a patient on P-TRIP, and she just had a left below the knee amputation. She is waiting for a stair glide to be installed in her 3-story home. Okay, so some points. So veteran is hardworking but occasionally lacks initiative. Attentive throughout most of her session, and once again, the word I want you to focus on is most. Doesn't say throughout entire session, but most of her session. So immediately, at least in the attention category, you know that this probably puts her at a level 4 at the highest level. So the therapist initiated the activity, which also puts her at a level 4 for initiation of activity. So veteran listened to the instructions and needed no repetition. The veteran was unable to self-initiate a rest break, but was able to listen to OT's feedback to take a break. Also, the therapist gave feedback while she was seated. The veteran stood and was able to follow most feedback. Once again, the keyword being most. She was able to successfully complete the activity, so no early termination. Therapist gave encouragement, and the vet needed this to complete more challenging tasks. So once again, those are the main points to pull out of that case study. Now, moving on, I'm going to go through each of those worksheets that I pulled up for you, and then you can kind of determine in the future what tool is going to work best. So in initiating activities, she is at a level 4 because she does rely on the therapist to initiate the activities throughout the therapy session. She does not actively seek feedback, like she does not ask the therapist, hey, how am I doing? Is this correct? However, she does sometimes and occasionally incorporate the feedback from the therapist. She's generally attentive throughout the session. She is not fully attentive, though, throughout the entire session. She does consistently follow instructions. She did not need any repetition of them. She does consistently work towards goals. And she does require encouragement to persevere, but she does persevere. So what you do is I added up all of those numbers, and I got a total score of 34, and I divided that by 7 and got a 4.8. So that means that she definitely falls under the category of a 4 and could possibly, based on clinical judgment, be moved up to a score of a level 5. But once again, that would be you as a clinician, what you think. But she definitely solidly fits into the RITS score of a level 4. So now I'm going to go through it on the decision tree and what that would look like. So did the patient consistently incorporate feedback, remain fully attentive throughout the session? So no. She did rely on the therapist to initiate, and she did not actively seek feedback. So how attentive was the patient? The patient was generally attentive. And requires encouragement and prompting to persevere seem accurate? Yes, it does. I did want to point out where this could be if you were unsure of how the scores broke up. You could have a patient, the one thing you have to be careful about using the decision tree is you could have a patient that does consistently incorporate feedback, but does not remain fully attentive throughout the session. So this would be harder because since this lumps those two together, you either have to say yes or no, and that can immediately disqualify a person from being a level 5 or immediately disqualify them from being a level 3. So just be aware of that and understand that patients are very complex and that there could be some gray area. So the decision tree is an awesome low burden tool, but just be aware that that could bring you to scores that could lead you down a path that will make certain levels of engagement unattainable. And once again, this is just another way of looking at why I scored this case study as a score of 4. And when it was sent out to about 5 different clinicians, majority of them said 4, with an exception of 1 or 2 that said a score of 5. So I'll discuss down here why I scored it a level 4 instead of a level 5. So a level 4, because the vet was generally attentive. She did follow instructions without needing repetition. She does not actively seek feedback, but adjusts activities based on feedback most of the time. Therapists have to initiate all the tasks, and the vet requires prompting and encouragement to continue tasks that are challenging. So the difference then between a 4 and a 5, if we go back to this, so a 5 would be looking more at, she does occasionally initiate feedback, which she did not at all. And also, she did not sustain full attention and goal-directed activity throughout the session. So that's one reason why I didn't give her a 5, is because she did have a decrease in attention and she did not initiate any activity. However, using clinical judgment, one could score a 5 and that would not be inappropriate. The point is you're looking at an average score, and there will be gray areas between some of the scores. Okay. Going to the next case study, I am now going to have you pause this video for a few minutes, and I'm going to have you either work by yourself or with a group partner, and I want you to score it on your own, and then we'll walk through the different scoring methods. Okay, so for this one, he does rely on therapists to initiate activities throughout the therapy session. He does not actively seek feedback, and he rarely incorporates feedback from the therapist, although he does, after extended time and extended explanation from the therapist. He rarely on his own will incorporate the feedback. He's inconsistently attentive throughout the session, having to be kind of redirected verbally a few times from the therapist. He does require repetition of instructions, and he does need frequent repetition and redirection towards his goals, and he gives up easily on tasks. So if you add all those scores, you're going to get a total score of 25 with a RITS score of a 3.5. So he definitely falls within the level of a 3 on the RITS score very solidly. But once again, clinical judgment wise, can determine if it makes more sense to be a level 2 or level 3 or level 4. So we're looking at decision tree method. So did the patient consistently incorporate feedback, remain fully attentive throughout the session? No. He did rely on therapists to initiate, and he did not seek feedback. How attentive was the patient? He was inconsistently attentive. So if you score at a level 3, so this is where you can look to see which describes your patient more. For this guy, he rarely incorporated feedback. He required repetition of instructions. He may work towards goals, which he did after extended verbal description and verbal cues from the therapist. And he did give up on tasks easily. So once again, when I gave this to some other clinicians, a few of them scored him at a level of a 2. So when we go down here, I'd say the main difference between the score of a level 2 and a level 3 is that a level 3 will he was occasionally responsive after increased verbal encouragement. So he didn't totally ignore therapists' feedback. I mean, initially he was a little bucky on the feedback, but he would ultimately, especially if you could incorporate real life events, he was responsive to the feedback. And this is another brand, he did attempt therapy tasks, even though he needed encouragement and prompting to do so. It's not like he refused, and he may initially have refused, but he always attempted the therapy tasks. And he did not request for the session to end early at all. So the next 3 case studies, I am going to let you guys as a group decide how many or if any you wanted to practice on. And here's the scoring method for case study number 3. Here's case study number 4. You can pause this video to score this case study. And here's the score for case study number 4. And this is case study number 5. You can pause this video to score this case study. And here's the scoring for case study number 5. And before we get started on the next section, I do want to point out that the last 3 examples, as you see, they may have gotten into slightly more gray area. So once again, what I want to emphasize is this is clinical judgment. A lot of the RITS score is based on clinical judgment. And once again, it is not a diagnostic tool, and it's not like you're trying to get everyone to a level of a 7. The focus and function of the RITS scale is to identify barriers and to help create specific goals for every patient if you notice an increase or decrease in engagement. So now I'm going to give you some examples of functional use of RITS scores. First, we'll start with case study number 1. So since the majority gave a score of 4, here is, and in your packet, there is a worksheet that is laid out just like this for each case study that you can use if you wanted extra practice with the other case studies. So identifying the main issues for the first that we discussed. She showed limited task initiation and required prompting and encouragement during challenging tasks. However, her strengths include she was attentive throughout most of her session, She adjusted activities based on feedback that the therapist gave her, and she does follow through with the activities despite the need for this encouragement. Okay, functional application of all this information. So Miss Jolene, she plans to return home to care for her 3 young children when she's discharged from P-TRIP. However, currently, with her lack of initiation, especially when she needs a rest break, and her need for prompting and encouragement with challenging tasks could prove challenging if going home to that type of environment in that role as a mom. If she is not initiating rest breaks during a structured therapy session, this could be a safety concern at home when she is caring for 3 young children. So possible strategies and example goals. So some example strategies could be to improve a vet's initiation of rest breaks and decrease the need for prompting and encouragement with challenging tasks. You could create a goal that encouraged this increase in initiation and decrease in prompting. So these example goals could include the vet will self-initiate rest breaks 100% of the time with no verbal cues from the therapist, and or the vet will complete all activities successfully with no verbal or tactile cues from therapists. Also, I think an important thing to realize is maybe educating her on the importance of initiating rest breaks and how to structure her day when discharged to conserve energy. And I think that this is important, and especially the education on conserving energy, especially for a mom of 3 young kids. But once again, since you notice through her score of the RITS that, hey, you know what? Clinically, she's doing pretty okay. Like, she shows up, she's very cordial, she's hardworking. However, when you break it out and realize that at a level 3, there is some decrease in task initiation and an increase in prompting and encouragement needed, that could lead to a more detailed and specific goal that you set up for her. And then the final thing too is to make sure you remeasure engagement to show improvements that either support a longer stay for her or support discharge. Okay, case study number 2. Scored him at a level 3. Identifying the main issues. He was inconsistently attentive. He was reluctant to follow feedback from therapists. He needs extra verbal cues and time to buy into feedback. He needs prompting to complete challenging tasks, and even then will occasionally not want to finish the task or activity. He also requires repetition of directions to complete activities successfully. His strengths include usually following instructions and feedback after extra coaxing. If feedback directly relates to his life, he will follow it. He will participate in complete sessions. And he did attempt most activities given to him, even if he was a little lucky at first to finish them. So functional application of this score. The veteran is demonstrating a lack of insight into his deficits. This lack of insight is getting in his way of completing assigned tasks and working towards goals he needs to meet to increase his functional capacity and community integration upon discharge. If he never gains awareness into his deficits, it will be hard for him to function successfully on his own after discharge. So strategies that can be used on this gentleman is, right now it just seems that he needs education on brain injury and deficit recognition. And that is imperative to improving therapy engagement, because if he doesn't perceive he has a problem, he is not going to want to be told what to do, probably. And you guys all have experience with that, I'm sure. So what Nikki often would tell me to do when I had a patient that would have a lack of an insight of some sort of deficit, she said, hey, set up a task that's a real life task that they fail in, so they understand why we are working on either specific memory compensation tasks or attention tasks. And since he really struggled participating unless he saw how it directly correlated to his life, another strategy is that every task should be related to part of his routine or role within the military or while home. If the activity cannot be functional within the context of his life, it will be difficult to get him to participate into the and buy into compensation strategies. So once again, things that you all already know when working with patients, and it's just being having all therapy be related to their real life and their real life context and roles and routines. And once again, just like the other guy, daily remeasure engagement to show improvement, and that could either support a longer stay if this gentleman is just really consistently scoring at a level 3 due to his decrease and lack of insight into his deficits. And that could mean, hey, you are going to have to stay longer, or maybe you start seeing that engagement improve to a level 4, which means that this could be an earlier discharge. So here is just an outline of the worksheet that you can use to fill in the rest of the case studies. So using RITS scores during rounds. In your packet, I have a weekly reassess template for use during rounds, and similarly to when you do weekly goal re-updates, having just this little blurb about the veteran's engagement for the week. So it talks about averaging out the daily RITS scores he got for the week and talking about whether that's improved, declined, remained the same, and then just briefly writing in possible barriers, whether it's medical, psychological, functional, cognitive, anything, why that score either increased or decreased or maintained. And then this could bring up discussions and questions in rounds such as, so why did the veteran's engagement increase or decrease for this particular discipline? And across disciplines, how did their engagement track this week, month, or et cetera, and why? And what as a multidisciplinary team can we do to change, to improve, maintain this veteran's engagement? So these are all really key questions to ask, and we already talked about and already asked these questions for sure, but this way with an actual consistent score, it kind of gives more depth and talking points. So an overview, the RITS is used to measure a pattern of engagement for individuals. So this is a daily score that you're going to give your patient after the end of each session on the scale of 1 to 7. It is used to create goals to intervene where you see there is a lack of engagement or a barrier in engagement. It is also used to change plans of care or intervention methods depending on what you see as their limitations to moving up an engagement level. It is also a low burden in the sense that it's only a 1 score scale. It's not a multiple question assessment after every session. And I am very aware and understand that anytime a new method is introduced to a floor, to a unit, to a way of already doing things, it is a tough transition. It is hard to implement a new strategy consistently into practice. And there are definite pros and there's definite cons. I do believe the pros definitely make it a strong contender of why this should become a normalized scale throughout the VA. However, I think it's good to open up discussion as far as what this looks like for you guys to actually use in your practice. So in the coming weeks and months or whatever, I definitely encourage you guys to have those discussions and across disciplines also. But I see a lot of positive outcomes that could come from measuring engagement. And if you have any questions, feel free to email Lindsay or you can email me and I will answer them to the best of your ability. Thank you again for listening.